Hello, fellow hospitalists, and welcome to Documentation Talks with Dr. Tom. As always, our objective here today is to help you get credit for the great work you are already doing and to help you avoid queries. In other words, we want to help you document like a genius. Today's topic is respiratory failure. First, let's talk briefly about the definition of respiratory failure in the coding and documentation world. Respiratory failure requires either hypoxemia or hypercapnia. Hypoxemia is usually established by a room air O2 sat of less than 90, but it can also be established by a blood gas on room air with a PaO2 of less than 60. Hypercapnia is established by a blood gas with a pH less than 7.35 and a PCO2 greater than 50. But it is very important to remember that besides hypoxemia and hypercapnia, you also need to document signs and symptoms of respiratory distress. Now, complete and accurate documentation of respiratory failure is really quite easy and requires only three elements: etiology, acuity, and type. Acuity can either be acute or chronic, or acute on chronic. Type is hypoxemic, hypercapnic, or mixed hypoxemic and hypercapnic. So an example of complete and accurate documentation for respiratory failure would be acute hypoxemic respiratory failure due to an exacerbation of COPD. Now let's talk a little bit about respiratory failure in the postoperative patient. First of all, it's important to note that postoperative respiratory failure is a patient safety indicator, or a PSI, which means it is defined by the Center for Medicare and Medicaid Services as a complication, and it is publicly reportable. In addition, Common Spirit Health has designated reduction of postoperative respiratory failure as an important patient safety goal in this fiscal year. The definition of postoperative respiratory failure is respiratory failure in the postoperative period that is directly related to anesthesia or surgery. To avoid a patient safety indicator, it is important to tie the etiology of your respiratory failure to a patient's comorbid condition rather than anesthesia or surgery. In addition, it is important to note that respiratory support in the immediate postoperative period, which is usually defined as less than 48 hours, is expected and should not trigger you to document postoperative respiratory failure. Now for a brief recap. Complete and accurate documentation of respiratory failure is easy and requires only three elements: etiology, acuity, and type. For your post-op patients, to avoid a PSI, avoid documenting postoperative respiratory failure unless the respiratory failure is directly related to anesthesia or surgery, and avoid documenting postoperative respiratory failure within the first 48 hours post-surgery. Only document postoperative respiratory failure if the respiratory failure is directly related to anesthesia or surgery. It's that easy. Thank you for listening, and stay tuned. Next month, we will be covering acidosis.